So the tears can't yet flow. So I have only one announcement, I believe, and that is about the advanced screening of LA 92. That's tomorrow evening at the Kennedy School, and that starts at 6. And there are posters available for you to get the details. So please now welcome to the podium Lauren Powell. She's a health disparities researcher, currently completing her master's in public health at the Kennedy School. She's a Sheila Johnson Leadership Fellow.
All right.
Thank you. Thank you for having me. So it's my pleasure and honor to introduce John Ataguba to the Fellows Colloquium at the Du Bois Research Institute at the Hutchins Center. In addition to being the Mandela Fellow at the Hutchins Center this spring, he is an associate professor in health economics at the University of Cape Town and comes to us with nearly a decade of acclaimed research experience across the African continent. John Ataguba grew up in rural poverty in Nigeria and at a young age lost many family members because they lacked access to adequate health care. Consequently, John has had a passionate concern for vulnerable populations and the lives of the underserved. This, in turn, has led to his research and teaching interests that lie in poverty, inequality, equity in health and health care, social determinants of health and health financing, microeconomics, and quantitative health economics. Regarded as a leading researcher in health inequality and equitable health financing in South Africa, in 2015, John received a Y1 rating from the National Research Foundation, South Africa. This is the highest rating for young researchers less than age 41 years. He is also the recipient of a range of awards for academic and research excellence. Upon graduating with a BA in economics at the University of Nigeria, he received the prize as the best graduating social scientist at the university. At the same time, shout out, yes. At the same time, he was also named as the best graduating economist. These wonderful achievements followed a several-year gap in his education between high school and college due to lack of funds. He earned a scholarship from the Swedish International Development Cooperation Agency to complete his master's degree at the University of Cape Town and Commonwealth scholarships to complete his PhD, which he also received at UCT, at the London School of Hygiene and Tropical Medicine, London. More recently, John has received the Claude Leon Merit Award for young lecturers for making significant independent contributions to the field, as well as the University of Cape Town Merit Award for exceptional contributions to teaching, service leadership, and social responsiveness. These are among other prestigious acclamations of his accomplishments as a researcher and professor. A prolific scholar, John has published numerous, I think nearly 50, articles in leading journals in his fields. John Ataguba serves as advisor to international organizations, including the World Health Organization, and to national governments in a range of capacities. Not too long ago, he was appointed by the South African Minister of Health to participate in 2 work streams for the country's national health insurance program. Please join me in welcoming John Ataguba as he speaks on looking into the past to understand the present for shaping the future, the case of health and healthcare.
I'm kind of speechless. Thank you so much, Lauren, for that generous remarks. And, well, I think it's too bigger for me to handle. But I say thank you anyway. I really want to thank everyone here for being colleagues, and especially for hosting me as a Mandela Mellon Fellow here at the Hutchins Center. It's been a very wonderful experience, though it started out, I was wondering, what am I going to do? Am I going to make it through, or am I going to come out happy or worse? But I tell you, I'm leaving here better than I came. And for me, it's a privilege and an honor, which I am heavily indebted to the Hutchins Center thank you so much, Skip Gates, for having me. I never knew you up until the time I thought about coming here. I also thank Krishna and her team, Sandra, Matt, and every other person who's been really, really hands-on in terms of providing support. Without these supports, I wouldn't have been here anyway. I also wanted to thank my wife, who unfortunately is taking care of my son, who's just been admitted to bed this morning. So I'm standing here strong and trying to compose myself, but it's well. So what am I going to talk about today? It's health and healthcare, especially in the context of an unequal society called South Africa. It might be very interesting to take a quick look at this for you to understand the context of apartheid and what a lot of people had to go through in South Africa, especially the black race. All Africans over the age of 16 must carry what they call a pass. A pass is like a passport that guarantees you access to the urban area, and without a pass, you can never get any employment. The moment you lose your pass, you are as good as a dead person. For whatever reason, whether it was burnt or the moment you lose it, you are as good as a dead person, basically. So under no circumstance may an employer pay Africans the same wage as a white worker, even if they have the same skills or whatever skills you might have attained. And Africans were really put into what they call the battle stands. The battle stands are usually homelands created specifically for the kind of tribe you originate from. Whether you have lived there or not, so long as that's your tribe, you have to go back there and stay. Doesn't really matter where you're born or stayed all your life. You only belong to that one. And of course, there are so many other things that were put in place, which you can take a look at that. No African may buy land in your own land. You cannot own or buy land on your own land. So you can imagine what that means. Only about 8% of land as at that time belonged to the black race. It's a very, very dehumanizing kind of situation to live in.
Today or under apartheid?
Under apartheid, yeah. So it's history. We're looking at the past now.
Okay.
So for us to have a look at inequality, I want to play this video so you can understand the context of inequality, even the present day of South Africa.
The Unequal Scenes Project is a series of aerial photos and video that I've taken with a drone over the most unequal parts of South Africa. While I was at the University of Cape Town, I learned a lot about how the city itself was designed with separation in mind. Those echoes of apartheid, those echoes of the past carry over. We're still dealing with them today, and it's so obvious when you look at the photos that the images of inequality that I'm showing directly come from apartheid, which is only 22 years ago. The first video I took of Masipumalele and Lake Michel, when I rose up from the ground and the drone changed perspective, I was shocked. I'd never seen that perspective before of the separation in South Africa, and I knew that I had a really powerful set of images. I think each of the photos in the Unequal Scenes project speak to a lot of different facets that are at play besides just inequality. They speak to homelessness, they speak to disenfranchisement, racism, urban planning, art. There's a lot of different ways that people have taken the photos, and they're very transferable in that sense. My main hope is that these photos provoke conversations, get people talking about these issues, and then those conversations lead to solutions through policymakers, through activists, through grassroots organizations. That's my hope. One of my favorite images, and one of the ones I think is the most powerful, is an image of an informal settlement located right next to a golf course in Durban. There's a thin fence between them. It just is incredibly poignant, that photo, to me, because a golf course is the icon of wealth and leisure to some extent. What I want to do going forward with the project is actually take it internationally. I want to take it outside South Africa. What I think would be really interesting is doing a comparative study of unequal scenes in wealthy parts of the world, like America or Europe. There's inequality everywhere. There's inequality and unequal scenes in every country in the world.
Okay, so you've had a little taste of how inequality is playing out in South Africa. Not much of a difference from what you have in the US, although different kind of context, but basically the same end. Under the apartheid government that ran between 1948 and 1994, the South African health system was very, very fragmented and separated. What that meant was that there were about 14 health departments that served different racial groups. Depending on what racial group you are, you have your own hospital, you have your own clinic, you have your own pharmacy to go to, and not anywhere else. In fact, the health departments for the Bantustans, that's the homelands, the traditional Black Africans, were not integrated, and this created further fragmentation. That is, if you belong to this health department, you cannot draw benefits from another health department, even though you are black and black. You can imagine that is. Health policy at that time, like many other major social policies, including education, was characterized by the objective of maintaining economic and political power and a high quality of life for minority white population. Health services for the majority black population, which the population of black at that time was about 80%, was heavily underfunded and rural areas were neglected. Similarly, access to health services was along racial lines, like I said, several public facilities for blacks and for whites. In fact, the Bantustans relied so much on church-based organizations providing hospitals and health services. When apartheid finally fell, as at 1996, a new constitution was adopted. So it was a new hope for South Africa. The government was sitting with a very, very big task of redressing inequality and inequity. And as at that time, the 14 separate health departments were amalgamated to become one national health department and 9 provincial health departments, corresponding to the 9 provinces we have in South Africa. And then at that time, the government, like I said, faced a very huge challenge to redress these inequalities and inequities. The first step that was taken was to provide free services for people who use public primary health services, that is clinics and community health centers. So these were actually services provided free of charge for the entire population.
And there was a cost before?
Before, like I said, there's a lot of cost, and as an economist, the cost we look compared to other kind of financial guys. When we talk about cost, it has a lot to do with social cost. Being unable to use a health service has what we call an opportunity cost for economists, which we value more than the financial cost you incur. So what's the current system like? The current system evolved to become a 2-tiered system, comprising the public and the private sectors. And during the transition from apartheid to what it is currently, the private sector emerged very strong. Private medical scheme, which is basically a form of, private medical scheme is a form of private health insurance, was created, although it dates back to 1889, that served mainly the white population that were mine workers, was one of the avenues through which the white minority are able to use private health services, which as at that time was considered as high-quality services. It was only during the late 1970s that membership of medical schemes included non-whites, although to a very small degree, very, very small degree. I've got colleagues who, writing in the Lancet in 2009, noted that, I quote, The development of a private sector was largely stimulated by corporate capital, particularly the mining houses. These capitalist institutions are far more powerful and have influenced the political economy of South Africa and its health system to a greater extent than in most other post-colonial African countries and Asian countries alike, end of quote. The wave of privatization that was predominant during the 1980s across Africa and also much of Asia helped fuel the strong influence of the private sector and led to the growth in the number of private establishments in the country. And by 2011, even up until 2014, there were more than 100 medical schemes. That is more than 100 private medical insurance schemes operating in the country. And unfortunately, these schemes only cater to about 15% of the population. So you can try and figure out the extent of fragmentation in the health sector. And they only cater for the rich guys. We'll know who they are in a while. So let's keep that on pause. The cost of private health services increased significantly over the past decades. This is driven mainly by the cost of private specialists and private hospital care. Unfortunately, the majority black population relied heavily on the underfunded public sector. Now let's look at the economic status of people in South Africa so that we can have an idea of who is who and how things evolved over time. If you look carefully, during the period of apartheid, which of course included 1987, where data was available, the principle of segregation, oppression, repression meant that incomes received by the black majority are actually restricted. The education system did not allow blacks to study courses that would put them on equal footing with whites. The kind of education that was given to blacks was basically something that would enable them to serve the whites. Over and above that, you are not allowed to get that education. And you can only be educated within your own homeland. You can't move to another homeland. And the kind of education given in your homeland is the only thing you have access to and nothing else. So the resultant effect was that income earned by an average black person was meager. Post-apartheid, however, income per person grew for both blacks and whites, but the difference between their incomes widened even further. So we expected that with the end of apartheid, things would now become better convergence. But there's no convergence. Divergence actually started even after the end of apartheid. It is only the Asian population that has been able to make significant improvements in income received per person. The overall picture is not encouraging, as the average income for a black person is consistently below the national average, both during and after apartheid. This has remained the case even though there is now the emergence of a black middle class. It's something for another study. It is arguably true that it takes time to completely dilute the effect of apartheid. However, the picture, even after 20 years, is still worrisome. Now, because income received by the black population has not increased substantially, poverty still wears only one color, fortunately. Over half of all the monetarily poor individuals in South Africa are black African women. It's very important to keep this in mind. Over half of poor people living in South Africa, basically black African women. And a further 40% of poor people in the country are basically black African men. So in total, over 92% of all poor individuals in South Africa are blacks. This proportion is significantly more than their population share, which is about 79%. Poverty is mainly non-existent among the white and Asian population. In fact, it is less than 1%.
What percentage of the black population is poor?
The percentage of black South Africa, that's exactly if you add, okay, go in. The proportion of black South African, which you can easily compute, is about 70%.
So of the whole black population, 70%
Yeah.
black South Africans are poor.
Yeah, because 92% are poor, 92% of the 79% poor. So
Yeah.
everyone is poor.
That sucks.
Yeah, everyone is poor. Yeah, I can tell you that. And the poverty line that was used here is we don't really have a national poverty line in South Africa, we're working on it. But that line is equivalent to about $2 a day per person. So you can imagine having 92% of Africans living on less than $2 a day. It's not nice at all. Okay. Now, economists use the Gini index. Some of you have heard about. Yeah, I can hear it now, yeah. Okay. Okay. Okay, let me keep going. Or is that mic on? No. Okay. Okay. Economists use what we call the Gini index. I'm sure a lot of you have heard about the Gini index before. It's kind of a popular index now as a measure of income inequality. If the value of the Gini index is close to 0, you have a more equal distribution of income. What that means is everyone has the same amount of money. However, as the value of the index gets closer and closer to 1, you're basically having a distribution that becomes very, very uneven. No. Okay. Okay, I'm happy everyone is supporting me. Good, yeah. Okay, like I said, if the value of the index gets closer to 1, you have a very unequal society. In actual fact, when the Gini index is 1, what it means is that only one person has all the income in that country. Very, very, very bad. Good. Consistently, income inequality is high among black African population group compared to the other population groups. In fact, we've had that among the white groups, population group, inequality is lower than the Asian, colored, or African population group. I think it might be worthwhile explaining this kind of categorization, what we call African, colored, Asian, and white, because we have a different categorization here in the US. So maybe I'll just go over it. What we call the African here is basically the guys that are indigenous black Africans. The colored population, not quite similar to what you use here in the US, but it's basically people of mixed ancestry. So if you have a white and a black marrying, the offspring is called colored. It's not black African. It's not black African in the context of South Africa. Then the Asian population is basically the Indians, the Chinese, Koreans. That's easily known. And the white, of course, is the Europeans, traditional European whites. So income inequality amongst the Europeans is basically very, very low compared to...
Any real sheep left?
This is getting... yeah. Yeah. This is getting...
We have left it grillable.
I'm sorry.
What's in that? Okay.
Oh, my.
We have a muesli and a.
Yes. Yes, over time. Oh my. This is yeah. Yeah. Yeah, maybe. I hope I can handle it. I hope I can handle this. Yeah.
You have such great graphics, but maybe if you could just spend a minute saying what they are, because you're not describing them, and you know.
You struggle to get them.
Yes, yes.
Okay.
Especially if you're at the back room, you can't see everything.
Okay. Hi. Hello. Under control? Are we? Okay. Okay. So, got it. Okay. Because I've lost track of where I am. Yeah. So no, not your fault. No one's fault. Like I said, economists use the Gini index to measure income inequality. But I think I skipped this while I was talking. Somebody wanted me to talk about this. So let me quickly talk about it. Because poverty is a phenomenon that is predominantly amongst the black population, there is a link, therefore, between income inequality and poverty. Okay? Because now you know the guys who are predominantly poor are basically the black folks, then it means that income inequality will really hurt them more than the other folks. So income inequality is stark in South Africa, very stark. The country is notoriously known as one of the most unequal societies in the world. Not in Africa, but in the world. The richest 20% of South Africans, as that picture will show you, enjoys over 70% of all income in the country. Try and figure that out. In fact, the top 10% of South Africans, enjoy more than 50% of all income. So the top 10% sit with more than half of incomes put together in the country, to tell you how unequal a country is. The bottom 40% of South Africans, if you add those two boxes together, the 2.2 and the 4.3, bottom 40% account for less than 7% of, less than 8% of incomes in the country, or less than even 7% of incomes in the country, which is really worrisome. Okay, then I started again by saying economists use the Gini index, and we now know what the Gini index is. It's a measure of income inequality that usually ranges from 0 to 1. If the value of the index is 0, it means that incomes in that particular society is equally distributed. Everyone has the same mean income. However, if the value of the index becomes 1 or gets closer to 1, then it means that income inequality is very, very high. If it's 1, it means only one person has all the income in that country, and she rides with it. Yeah. And we've seen consistently between 1993, shortly before the election of Mandela, which was in 1994, that income inequality has remained pretty much the same, or increased, but the same pattern. Africans, you see on the far left there, have income inequality ranging from about 0.6 to 0.7. You know what that means now? Getting closer to 1. Even though you see a very high income inequality occurring amongst the whites, keep in mind that the white population already enjoy a lot of income that is far above the national average. So inequality is basically measuring how these varies even within the white population group. So they're already not poor, so you're measuring how these varies amongst them. So even though you see the kind of peak there, it's not that something to worry about. Well, not great, but nothing to worry about that much. Now, let's take a quick look at the burden of health and health disparities in the countries, or in the country, what we call health inequalities. Even with the challenges I've shown so far, the country has made some significant progress since the end of apartheid. For instance, access to some social services such as water, electricity, housing, sanitation has actually improved over the years. However, some challenges still remain. And some of these can be linked inextricably to apartheid and the high level of income inequality in the country. There's high incidence of rape in South Africa, a very high incidence of rape, not just rape of ladies, but both ladies and men. So there's high incidence of rape and violence. For instance, in 2005, about 117 rape cases were reported per 100,000 people. Per 100,000 people, you have about 117 rape cases reported. Not to mention the unreported incest kind of stuff that happens, which is very common in many African societies. And over 18,000 murders. Yes.
So John, that graph is saying that life expectancy among all groups except Asians has fallen between 85 and 2004.
Yeah, I'll come there. Thanks for pointing that out. I'll definitely come there. Over 18,000 murders were reported in 2007. 18,000 murders reported. Can you imagine the extent of violence and crime? So TB incidence prevalence, for instance, is highest among the black group compared to other racial groups. Life expectancy at birth dropped significantly for the black racial group between 1985 and 2004, likely because of HIV and AIDS. Now, if you look at the prevalence of HIV and AIDS there, it basically tells you what happens to life expectancy. It's more amongst the blacks, so it means their life expectancy would obviously drop. And you could see that sharp decline in life expectancy. In recent times, however, due to great improvements in the rollout of ARVs, which actually started around 2003 in the country, and changes in eligibility criteria in terms of when you begin, you go on ART, the difference between life expectancy of a HIV-positive individual and a HIV-negative individual is actually negligible at the moment due to advancements in science. Okay, now let's come back to the Asian population. Now, there is a link between income and health. We have what we call the gradient. What that means is that people who are healthy, people who are wealthy tend to be healthier than people who are less wealthy. And that is playing out here. If you notice, incomes for Asian population group increased dramatically. And that is also playing out when you look at life expectancy. Their life expectancy also increased to satisfy the principle of the gradient, clearly. The other groups, the whites, sometimes we're unable to explain why that drop in life expectancy, especially for the whites. But overall, there's a decline in life expectancy, which is worrisome. Now, even when you analyze the burden of selected diseases, what we found is that diseases such as TB, diarrhea, HIV, can mention that up until trauma, are heavily concentrated amongst the poor, and by implication, blacks. Even when you look at disability, the concentration is more amongst the poor. What that graph means is anything you see below that line, the horizontal line, is heavily concentrated amongst the poor. And the longer that drip, the more effect it has on the poor compared to the rich. Only things like flu and acute respiratory tract infection and diabetes, for instance, are what you find reported commonly amongst the rich. But if you look at physical disability, hearing, sight, speech, emotional, intellectual disabilities, all are heavily concentrated amongst the poor. Good. Now, the link between TB and HIV is very well known. A lot of people know what they call the comorbidities. People who have HIV are prone to so many other infections, and one of them is tuberculosis. Part of the causes of high TB prevalence in South Africa is linked to the history of mine workers. So now this is a picture that was taken in the 60s, around late 60s. So you could see how mine workers have to sleep. There's also space for someone to sleep on top there. There's space there for someone to sleep here. There's space here. And these are how black mine workers sleep. And you know what that means in terms of epidemic transfer from one person to another. In general, the country still continues to battle with high prevalence of TB and HIV in the world. If you know the statistics, South Africa or Southern Africa has the highest prevalence of HIV in the world. It's a big, big, big problem. And that partly comes from what happened during the apartheid era with mine workers and how they were treated. Now, alcohol, taken generally, emerged as a leading risk factor for the high burden of disease that we have in the country. It is implicated in injuries, intentional, unintentional road traffic accidents, as well as violence, very much common in violence, and other behavioral disorders. You could see, if you see that clearly, what that means is these are major risk factors of diseases, and alcohol use is the largest. Economists compute what they call the DALYs. DALYs are basically disability adjusted life years. Disability adjusted life years is we assume that if someone lives in disability, how long will they live if they are to live in that disability? So you'll be able to compute how much less they will live. If you remove the disability, the difference between how much they will live without the disability and how long they will live in the disability will tell us basically the impact of the disability on life expectancy. So it means that alcohol contributes significantly to a very large proportion of, including high body mass index, which of course is a precursor to obesity. Good. Now, one of the leading causes of the current alcohol consumption pattern in the country is linked to the so-called dope or tot system. Although this system was outlawed in 1960, it was only enforced with the coming of the democratic government of Mandela. What does this mean? Under the so-called dope system, there was a kind of dual remuneration system of labor for black farm workers. That is, one of the jobs that blacks were only allowed to engage in, unfortunately, not white-collar jobs. So black farm workers were compensated partly with alcohol and partly with liquid cash. So at the end of a week's job, you're given your remuneration. Half of remuneration is in alcohol and half is in cash. So you go home and have fun. And that happens to the black farm workers. Now, this system entrenched the culture of drinking and contributed significantly to the current challenge of alcohol abuse in the country, which of course we saw is implicated in major burden of disease in the country. Now, the incidence of what we call the fetal alcohol syndrome, some of you might have heard about this, is a disorder that children get if mothers drink while they are pregnant. Not all mothers will get it, but there's a high chance that you get it if you drink while you're pregnant. Now, the incidence of FAS, which is the fetal alcohol syndrome, in South Africa, especially in the Western Cape Town region, where the dope system was really, really prominent, is considered one of the highest in the world. So if you study fetal alcohol syndrome, you will definitely encounter Cape Town, where it's seen as the center of a FAS. So in that picture, you could even see that in a cornfield on the Rizal farm, a boy drinks his midday wine ration. Midday. I tell you, he has one in the morning, a boy. Not the father, a boy. Possibly at the age of 12, 10, less, thereabout. From a God given to him by a farmer's daughter. So you could see the farmer's daughter looking at him until he finishes that, and if you want more, you get drunk, basically. Okay. Now, with that in mind, we now know that there is need for health sector reforms in the country, and that is part of the things that I have focused so much on over the last a couple of years. Now, if you take a look at the entire health system, it has been shown that the rich benefit mainly from public health services that traditionally should be serving mainly poorer population groups. Now, how do we understand this? If you look at this carefully, this is the share of public health service benefits. That is, if you use public health services in South Africa, the bottom 20% of South Africans enjoy that, and they need more than what they enjoy. But the richest 20% of South Africans enjoy that box, which is bigger than what they need. That's a problem. What we expect is that if you need this, you should use equally the same amount of public health services, or better, more than you need. So this is what we call the inverse care law. The inverse care law is basically a law that kicks in that people who need more services receive less than what they need than people who do not need these services. So what is very worrisome is that those who receive health services benefits are predominantly the rich that need these services less. And if you take a look at the burden of disease I showed you earlier, heavily concentrated amongst the poor, predominantly blacks. Again, if you decide to say, well, let's not look at just the public sector, let's amalgamate the public and the private sector and have what we call total health service benefits. In South Africa, you find even a more stark picture of inequality. The bottom 20% of South Africans need this, but they use that amount. And the richest 20% actually use that, but they need that. So it re-entrenches and basically reinforces what used to be during the apartheid era. Okay, although it is increasingly being recognized that healthcare or health services is one ingredient in the remedy for health inequalities, it is still very relevant. Other sectors that I and my colleagues have demonstrated to have significant impact on health inequalities in South Africa include education, housing, infrastructure, and employment. So in addition to addressing these other sectors, the health sector has a major role to play in redressing health inequalities and health inequities in South Africa. Now, I use these terms, health inequality and health inequity, and some of you might be wondering, why do I use these terms? There's a difference between health inequality and health inequity. Health inequality is very simple. So long as something is no longer equal, it is unequal. That's inequality. But inequity is inequality that is unfair and that can be changed. If there is something that is unfair and we have technology and whatever to change it, it's inequity. So inequity can exist in equality. There can be equality, but inequity. So the fact that something is equal does not necessarily mean that we're dealing with equity here. Of course, we move to the realm of philosophy in arriving at that. Okay, so in addition to addressing these other sectors, like I say, there's a major role for the health sector in redressing inequalities in South Africa. We have to keep in mind that such a reform will be beneficial to the poor, who are predominantly black Africans. Okay, now let me talk about things happening. Now, this is at the heart of several attempts that have been aimed at reforming the South African health sector. In fact, since the end of apartheid in 1994, there has been several attempts at ensuring some form of a national health insurance that will guarantee access to health services for the predominantly black South Africans. So you could see more than this. I just basically picked a few of them to show you the many policies that have been developed right from 1994 to even last year, dealing with health sector reforms. And one was the one that Lauren mentioned about the national health insurance that we are currently working on to be able to see how we can make things better, hopefully. And I'll talk about that now. So the bulk of my current research at Harvard is trying to understand reform agenda in South Africa and comparing these with the US, as these two countries have some similarities. E.g., there's a large and powerful private sector in these countries. And there's the issue of rising healthcare costs. We need to bring down healthcare costs. You hear that very often about economists talking about it. And we also know that some people will say, well, no one knew how healthcare reforms can be very, very complicated. In fact, health economists know how complicated that is, in actual fact. So it is hoped that lessons can be learned both ways, South Africa and the US. Now, I'll conclude by saying that public policy, including health policy or health sector reforms, need to be guided by evidence and science and not rhetoric. Reform should not be based solely on political ideology or expediency. In some cases, there is a fortunate wedding between political statements and what the policy direction should be. However, to make it a marriage beyond just a wedding, sound policy analysis are required. That is where history, lived experiences, and potential impacts are very, very necessary. We must also keep in mind something that goes beyond utilitarianism. If you understand the concept of utilitarianism, what we are saying is to go beyond just achieving a greater sum. But we have to look at who's left out or who's left behind. Utilitarianism is about achieving the greatest sum. So long as the greatest sum is achieved, we move forward with utilitarianism. However, you can achieve the greatest sum with misery. If a minority group is in misery, you have a very large sum. So it's not all about, a large sum can be achieved by only one person putting into that pot, and the rest in misery. So it's important to go beyond utilitarianism or such ideals, but to a real desire to redress and address the needs of all, including minorities and the vulnerable within the ambit of available resources, technology, and culture. And that's where I would end. Gracias. Thank you. Yes, please, bring it on.
Well, thank you for this really informative and devastating portrait of issues. They turned the whole system. No, it's on. Okay. Just thank you for an excellent talk showing the stark economic and health reality in South Africa. Can you say a little bit about what are the major barriers to passing the kind of legislation you think is necessary to begin to move it in the right direction? What are the biggest challenges facing them?
I was actually trying to run away from that question, but I'm glad you brought it up. Because that's at the heart of political economy, and which is exactly the kind of stuff I'm dealing with. There are a whole lot of them. Let me talk from the South African perspective. Remember, I talked a lot about capitalism and the emergence of neoliberal kind of thinking. And what that meant is when apartheid crumbled, a new form of oppression arose. So you have apartheid ending, which is about color of skin, but now became the size of pockets, of your pocket. So basically, it's like replacing a new wine in an old bottle or something of that nature. So what that meant was that there's a growth in a very strong private sector. Now, the private sector in South Africa is so strong that it's difficult to reform without bringing them to the table. Now, bringing them to the table means that you also need to accept some of the things they want to put on the table. But the way the government is going is to ensure that we bring together the private and public sector, but more importantly, ensure that the public sector is strong enough to provide services that people would not worry so much. We suffer a lot from poor quality of services if you go to the public sector. So people are worried. If there's so-called national health insurance today, and I have to use a public sector service, am I going to get the same kind of service that I'm getting now when the NHI or whatever kicks in? It's a big worry. So government responds by saying, well, what we'll do is to phase out the implementation of the national health insurance into about 15 years or thereabout. The first 5 years, we focus so much on restructuring the provision of public health services to make sure that health services are of acceptable quality for people to use these services and trust in the system. Because the moment people lose trust in any system, that's all. It falls. Okay, now, back to history. There were so many attempts to institute something like this in the past. But part of the reasons why it failed, or they all failed, is lack of political commitment. The moment political commitment basically fades away, then there's no one to hold it up. You don't expect, the private sector wants to punch things. So the moment they punch it, and then there's no one to hold it, it falls apart. So there are a whole lot of things, people not trusting the system, a strong private sector, and the issue of, even within the public sector. Now, if you understand what you call public financial management system, it means that there's a way money flows from one level to the other level to the other level. If there's any reform, that's going to alter how money will flow from the system. And if I used to be a budget holder before, one of the things I would fear is lose my power, because that budget is my power. So if there is any change that moves how money is going to flow away from me, then I'll lose my power. So there are so many of those kind of issues, a lot of them, that come to play. Why such reforms are really, really slow, very slow. We're trying to engage a lot with many stakeholders, with private sector, with public sector, international organizations, and even the WHO. But of course, you always hit these kind of rocks. And the growth of the economy is another important one. The moment people hear about this kind of stuff, they're like, the economy is not growing. Where are we going to get money to do this? Now we're in a recession. Oh, okay, now the growth rate is not what we projected. So where are we going to get this kind of money to inject into the system to provide these kind of services? Because from history, we know that once the system kicks in like that, people will want to use more services. People who previously thought they are unable to use services will now be privileged to use the services. So you have a spike in utilization rate. So you have to be prepared for such, which will definitely happen. You have to prepare for it.
John, thank you so much for it's me.
Yeah,
thank you so much for an incredibly rich talk. And I guess I have a comment and a question. The comment is, I couldn't help but think of the resonances of what you're describing in South Africa with a lot of American corollaries, but particularly with Native Americans, right, and reservations, the incidences of violence, of rape, of alcohol misuse, and the historic roots of that and how that's played out, right, and the ways in which that's shaped Native health landscapes. So, you know, beyond, I think, the issue of a national health insurance system, I think there are a lot of really rich possibilities to be teased out because they're so similar. The question is, I remember a few years ago in the media, there was a lot of discussion of the poaching of particularly extremely talented nurses who served in the public sector, who had an incredible depth of experience with HIV/AIDS and who were being brought to the global north, basically, for that experience with incredibly competitive offers. And I guess I was curious to see, is there a similar kind of process that's taking place between private and public sector in South Africa, where the talent that is in the public sector that remains domestic in South Africa is then getting sheared into these private services because of this kind of wealth disparity?
Interesting. I like that. Now, the issue with brain drain is very stark. You mentioned nurses. South African nurses have been poached, or whether poached or they, I don't know which term to use, but they moved out, whichever force, whether it's a pull or a push kind of factor. They moved out. And mostly I go to countries like the UK, New Zealand, Australia. These are major destinations for South African nurses. Yes, there is the issue of pull and push between the public and private sectors. Now, the public sector is sitting with a big problem in terms of human resources. The bulk of human resources is located within the private sector. The public sector has a very like I showed you the issue of financial resources. The same applies to human resources as well. It's a big problem. And that's why the national health insurance cannot progress without bringing on board the private sector. So part of the agenda is to what we call contract. That is to be able to tell the private facilities to provide services to people who are NHI patients, and then they are paid the same rate that they will be paid elsewhere, so that we can tap into the resources that is available within the private sector. So we want to look at distribution of resources in the country rather than focusing on the public sector. But perhaps as soon as the public sector is revamped, hopefully, then you have people moving back from a private sector to the public sector. And economists talk a lot about what they call the dual economy. Usually it's used for rural urban. That is, people migrate from places of low wages to a place where you have high wage. Perhaps when wages equalize, hopefully, then you would not have much of a difference between whether you reside in the public sector or the private sector. But another issue is the issue of moonlighting. And moonlighting is basically a situation where you're employed as a public provider, but you have a private practice somewhere where you refer your patients to for follow-up visits. You can come there for better quality of services. And of course, that's done to people who are rich on a richer level. Yes, there is maldistribution of resources between public and private. There's also policies that are being thought about to increase the number of health professionals. Whilst there's a problem with the balance, there's also a problem with the quantity. So we have problem quantity and distribution. And this is a classic problem in economics, where you have distribution issues and quantity issues. So, yeah.
Could you explain
Yes.
why the income for whites in South Africa increased after apartheid, which was on your slide? And then my other question was, are there other examples in the developing world of national health services? And if so, are you also looking at those examples for comparisons?
Two questions I got. Let me start from the last. Are there other countries, developing countries, with some kind of national health insurance? Yes, of course, but to different degrees. The problem we face is that it's very difficult to compare health systems directly. There are many reasons why that is the case. Countries operate differently. So you cannot transport a system that works in the UK and move it to the US. It might not work. Or transport something from the US to Canada. Might not work. Yes, what we did, or what I have done over the years, is to look at many health systems. In Africa, let me start with a few examples. One is Rwanda. If you understand the context of Rwanda, Rwanda is a country that moved from some kind of mutuelle de santé, which is basically the kind of community health centers, to form what they call like an overall health insurance. They moved from a different starting point. Okay? Then you also have countries like Ghana, which has pretty much similar experience with Rwanda, starting out again with so many community-based health insurance that were amalgamated and later pushed and moved over to national health insurance. But one of the major challenges facing Ghana, for instance, is sustainability. They're hitting the wall in terms of where they're going to get money to keep this system running. There are a whole lot of reports here and there. Well, it's a success story, and suddenly we hear, oh, no, they're battling with a lot of issues like enrollments declining from what it used to be. So, in essence, there's a lot to learn from many countries. But why I'm particular about the US is that the similarities we have with the US is more than the similarities we have with Ghana, with Rwanda, or with other African countries still battling with health sector reforms, like the private sector and capitalism. South Africa is the most developed country within the sub-Saharan African sphere. Well, once in a while, Nigeria claims to Trump, but I don't know. Yeah, it's an issue for debate. So it's sometimes good to compare countries who are within the same kind of level of development or who share similarities in terms of the issues that you want to reform primarily. Then the second one is why do we, what explains the growth in income for the whites even after apartheid? There was a musician that sang something like that taxes will always be constant. Yeah, I think it's Celine Dion. Some things are very constant. Rain tax, she mentioned a few other things. In economics, incomes always increase.
Can I just say, though, that your graph showed, it seemed, in the decades before the 1990s, that the income didn't actually jump very much, but it was after apartheid that it actually increased a lot. It seems. Was it this one? Yeah, maybe that one. So it seemed like it was sort of relative, immediately before, and then you start seeing this big increase.
Okay, interesting. Now let's keep in mind that the graphs are not spaced the same year. I mean, between 1987 and 1993 is different. The time gap is different from 2000, 2008 kind of stuff. So it's not really a trend to be seen kind of comparing that peak, how it peaks, basically. Yeah, not equal intervals. I don't want to use some technical terms. Yeah, basically, not equal intervals. So what that means is that we cannot compare that trend by just looking at that peak. But I can speak to policies that were in place up until 2008, thereabout. Okay, now there is a general increase in terms of overall income in the country. Now the increase in income in the country is driven largely by key sectors. Mining is one, manufacturing, and recently trade and services. Now, these services are traditional services that benefit the whites compared to the blacks. So it's not surprising that you could see the Asian population there because they came in terms of trade and services, and they were able to increase their income to that level. So perhaps that's part of what explains that. But if you look at it carefully, it's still an upward trend anyway for all racial groups. There will always be an increase. That I must guarantee you. Always be an increase. But yeah, I hope it answers your question.
Thank you for your talk.
Oh my.
Was it me?
Oh,
Okay, sorry.
So, John, I wanted to go back to the question that you were discussing about, the difficulty of merging the two, the public system and the private system, and people's anxieties that they wouldn't get the same level of service. When I think about a situation in Jamaica and what it would be like to go to the public hospital, and the big barrier there is very limited resources that the government has. And that I wonder then, is the private sector healthcare system really adequate to meet the needs if in fact, if all the resources of private and public were pooled, wouldn't there in fact be a steep decline in the level of service? That's the first question. And then the second question, the extreme inequality among black Africans in South Africa would seem to indicate that there are some very wealthy black Africans, because if you're saying that 90% of the poor are black, and then there are these high levels of inequality, that must imply there are some extremely wealthy individuals, a few extremely wealthy individuals that are driving the Gini index up. Is that correct?
Correct. So that's answered. Correct. Like I said, I mentioned the issue of rising middle class for the blacks. There was a policy put in place which is basically the BEE. In South Africa, it's very common. Every firm has to be BEE compliant. That is Black Economic Empowerment. You should be able to demonstrate every year that your labor force is actually diversified according to the population dynamics in the country. If you're unable to demonstrate that, then in terms of registration, you're going to hit the wall in terms of registration. So that also explains why a lot of blacks are already coming on board, becoming even CEOs, and earning a lot of money. However, once that happens, it means that you're going to have high inequality amongst the blacks. The moment you have a few earning a lot and a lot not earning, then that's going to widen income disparities. Yeah, so that's a big issue within the country at the moment. You might be shocked that the richest South African might even be a black man. It's very possible. Not even a woman, a man, which is a big problem in terms of gender issues in the country. Yeah.
Hi, thank you, John. I really appreciated the talk. I've learned a lot today. I just have a quick question about the role pharma might play in South Africa compared to its role here in America.
Pharma?
Big pharma.
Okay, pharma. Okay.
Pharmaceutical companies.
Oh, pharmaceutical. Oh, I thought it was
Sorry.
pharma. Okay, yeah. Okay.
No, yeah. Pharmaceutical companies. And I was curious also on your list of different ailments, cancer wasn't included. And I wonder if cancer has as much of a role in South Africa as it does here. And finally, opiate addiction. I'm wondering if that is also something that you see in terms of disparity of how pain management, you know, if you see a difference between races in terms of Africans versus whites and Asians. I don't know if you've done that research, but there's been a lot of research here in America on how pain management is distributed and why there's so much opiate addiction here. And I'm just wondering the correlation in South Africa.
Interesting. Let me start with the last one. One of the things we battle with, especially in townships in South Africa, is meth. They call it tick. In South Africa, we call it tick, meth. Now, the problem is that it's something that has been growing over the years. People are so addicted to that. And I have not done a research on that, not because it's not interesting, but I thought about it. But it's something that is common only amongst the poor, not the rich. So meth addiction is predominantly amongst the poor. We don't have much of cocaine stuff, opium, opioid, or whatever you call them, all the or the pain management.
Within the healthcare system.
Oh. No. We don't have much of a problem with that. No. Okay. Then the other one is pharmaceutical companies in the country. In the context of South Africa compared to other developing countries, yes, the pharmaceutical companies are part of our problems. We fight a lot with them. But what we do as much as possible is to have what we call the reference pricing. Now, what the reference pricing means is that you have generics as compared to the branded products that will be provided, and usually doctors are encouraged to prescribe the generics vis-a-vis the branded commodities. Reason being that it's the easiest way to push down cost over time for the branded commodities to basically come down, because once demand and supply, the less people prescribe those drugs, price will definitely come down. But one of the major challenges is that medicine prices contribute significantly. I don't know whether I showed it, but I wish I put it there. Contribute significantly to the cost that people incur when they go to seek health services. It's one of the leading costs that people bear if they have to seek health services. So it's a big issue. But I don't think I don't know the US that much, but I don't know whether it's the same kind of level in terms of, I can't compare whether it's the same between the US and RSA. Yeah. Then the third one, which I couldn't get, the cancer. I particularly wanted to do something on cancer when I showed that particular graph somewhere there, but unfortunately, data sets would not allow, cancers are not reported that much. So you find them dotted. So to do a very rigorous inequality analysis, you end up finding it's 1% or 0.5% of population. So you can't be confident that the distribution you're arriving at is the same or a fluke or something. So it's scattered around. But you can only analyze when you have a distribution that is rich, between the rich and the poor. But yes, cancer is a problem. All various kinds of cancers are problems. Breast cancer amongst women. Yeah, there are issues that we deal with in the country. Yeah. Chronic conditions, yeah.
Is it on?
Well,
sorry,
for a long
Harry,
time, yeah.
we behind you were queuing.
I'm sorry, Lorraine, just so there's not confusion.
Okay. Whose turn is it? Okay.
Oh, I'm sorry, Lorraine.
Oh, no, who's
Okay,
Hillary first? Hillary first?
Okay, thank you. So I try to be short. Thank you, John, for this presentation. I have a question and a comment, I think. So one is, are you not worried that the way you present this data and somehow what it suggests might end up being within the framework of Afro-pessimism? You know, that you kind of highlight the dysfunctionality of these societies, the dysfunctionality of the post-apartheid government, and somehow reproduce certain cliche assumptions people have about this country. So I was wondering how you feel about that. And one way to maybe alleviate some of the risk around that would be to maybe say something about the differences between areas and regions in South Africa, you know, what it means, what these issues mean in big cities like Cape Town and Joburg, and what they mean in smaller towns or in rural areas, what it means in the former homelands or Bantustans, so that, you know, one gets a dynamic picture of how things might look on the ground. And the other question is, how do people cope? You know, how have people been coping with questions of disease and health? And obviously the HIV AIDS issue, you know, has been disrupting things in a way that might be different from questions of cancer. You know, how do communities, families cope with cancer, with or minor diseases that might be somehow, yeah, they can handle. But when do things become so disruptive that they actually have all these repercussions? So if you can say about these differentiations within the question of health and, you know, social inequality.
Yeah, the issue of how people handle it is interesting questions. Currently, the public sector, the way it's designed is that it provides primary healthcare services. And if you're poor, currently, it's very possible that you could go up until receiving the best quality of services you can ever get without paying anything, because fees are graduated. There's what they call the uniform fee schedule. That is uniform patient fee schedule, UPFS. Now what that means is that if you earn nothing, you can move from the lowest level of service provision to the highest, and you get open heart surgery, whatever, free of charge, without paying anything. However, the challenge is the waiting list. Challenge is that, but you can move from 0 to 100 without paying anything. Then if you are within if you use the private medical schemes, one plus is that the private medical schemes have been forced mandatorily to provide what they call prescribed minimum benefit, including all the chronic conditions. That is, all chronic conditions have to be covered. So you can't exclude someone because the person developed cancer or developed something weird. You can't exclude a person. So this kind of checks have already been put in place. So in a way, that's some plus. However, the problem is that costs escalate. And the system has not been able to generate what we expect. That is, use of health services should be in line with need for such services. If that had been the case, then we wouldn't have been bothered about reforming the system. Yes, I get your point that it's always good to talk about the pluses and minuses and stuff like that. But if you go into a politician and you really want to make a case and you finish with a good, in the press, the next thing you hear is, well, John presented something, he talked about how we're doing well, and then they never get to mention, well, the last tale, they say, well, there are places where we can improve, but say we're doing well. And that ends there. And then you say, but this is not exactly what I wanted to say. And so perhaps it's important to, first of all, highlight the challenges the countries face and look at ways to begin to think of policies that will address and redress them. There are lots of positives that I could have dwelt upon, but because of time, and I'm really keen on trying to bring out the issues that need reform. There is difference between what is experienced in, an urban area in South Africa is even more heterogeneous than a rural area because you have urban slums. You've seen the picture earlier. In Cape Town, for instance, if you've arrived in Cape Town, the moment you arrive and you live in the airport, the first 5 minutes you going through shanty towns, and you're like, am I in Cape Town or in somewhere else? And then suddenly you hit affluence. It's like a switch. There's no transition. It's just a switch from 0 to 1. Just a thin line, 0, 1. So in that kind of situation, violence will definitely erupt because you can't look over the fence and see your neighbor enjoying a very luxurious life and you're struggling to survive. Just over the fence, like kind of stuff. So the experiences vary if you move from rural to urban. Even within urban, it's not homogeneous, it's heterogeneous. And sometimes we find it difficult to explain this. And that's where a couple of my colleagues have done a lot of work in terms of trying to understand lived experiences of people using very rich qualitative analysis, which of course I'm not an expert in. I don't do much of that. I do mainly my programming stuff and stuff like that, less of such, yeah.
Yes, thank you very much for that really fascinating presentation. I look forward to reading whatever publications come out of it. Now, part of what I was going to ask you has already been asked in terms of the urban-rural difference, but the other question I had was, is there a significant difference within the white community between the Afrikaners and the non-Afrikaners in terms of how they have done in terms of income increases, et cetera?
Wow, that's interesting. Let me give a quick history about what he's mentioning. The white population in South Africa is composed of two guys, the Boers, called the Afrikaners, and the British guys, okay? Now, the Boers are predominantly people from Netherlands, and then the other half is English speaking. They were forced together in what they call the Boer War that happened sometime. Now, between these two groups, over time there's less of data collected that differentiates which of these you belong to. So when we collect data, it's either white, black, Asian. We rarely dig deep to know which race, whether if you're white, whether you're Boer or originally British white. Now, the only thing we can say is that these communities are kind of separate. So we can infer something from the ways these communities are. Afrikaner communities are different from the traditional English communities. So if you compare them, they are different. So it's not easy the Boers are have a more traditional kind of living. They have a sense of community that is similar to the sense of community we have in the African culture. So if you want to analyze the Boers, it's kind of different from analyzing the British white communities. So, yeah, I've not looked at that before, but yeah, I can't say much. Yeah.
Brother John, thank you so much here for your presentation and enlightening us with this colorful graphs and also depressing at the same time. These are the issues, right, which has a popular public opinion in South Africa now. especially in recent years with the emergence of left-wing political parties like EFF, which targets basically issues of social justice and economic disparity. And then we have seen emergence of decolonization movement in the university campuses, UCT, start from there. So I was wondering, how would these issues fit into this imagination, A, and B, if it is part of their discourse, how do you think they're going to entangle this with the larger goal of, decolonial movement?
That's a very rich question and very deep. South Africa is going through a hell of a transformation. My university, University of Cape Town, and some other universities, Witwatersrand, Stellenbosch, Pretoria, and a few others, even the University of the Western Cape, for instance, have experienced great trouble over the last 2 years. Now, what's the problem? Students are now taking things into, to another level. That is, they want redress now. Do it now. We're tired of hearing stories. We want it done now. So what's happening is transformation is on a very high, it's high on the agenda. Yes, coming to the stuff I presented, a lot of what I presented have really informed the move towards the national health insurance. So if you're privileged to pick up the National Health Insurance policy paper, you find pretty much some of the research I've done and I've presented here, how they've been able to use this research to advocate for transformation and change. But again comes the issue of political expediency, political will, and stuff like that. There's an extent to which I can go as an academic, I put out the facts as much as possible, but whether the facts get used or not and how they are used is determined in another realm, the political realm, which is it's a problem. It depends, the problem. So yes, they will be used, but the extent to which they'll be used is, go there, yeah. Harry has been up for. Okay.
Hi, John. Thank you so much for this excellent presentation. I couldn't help but thinking about Kenya while you were presenting, which is where I'm from. I'm curious to know how you are conceptualizing the public versus the private. Because with the complicated situation that you have painted for us, what is the place for mission hospitals, for example? What is the place for military hospitals, for example? The place for African traditional healthcare systems in the rural areas that you have described? What is the place for that African traditional medicine and the healthcare systems that they have in those areas? As well as in universities where you might have government funding as well as privately funded schemes. I just want to find out more about whether this is the right framework to think about this very complicated and important topic that you're working on. Thank you.
Okay, good. Kenya is like my neighbor. The situation in Kenya, let me go back to the time when the Ministry of Health was split into as many as possible, again for political expediency. So you could have many ministries of health. One is for public health, one is for blah, 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 stuff like that. Now let me talk about South Africa now. The issue of mission hospitals is not as it is in other African countries. It's not much as it is in other African countries. But even if there were to be, or places where they are particularly classified as private. So under the private, we have what we call private for profit, and then private not for profit. So mission hospitals are usually classified as private establishments, but by and large, not-for-profit organizations. So if they exist, they will definitely come under that. But if you have organizations that are purely for profit, private practices and stuff like that, will go under private practitioners. Then if you talk about traditional medicine in South Africa, it's very, very common, very common. In many other African countries, I'm pretty sure it's the same in Kenya. You have the traditional medicine, even the sangomas and stuff like that. Now, there's a whole lot of issue with regards to regulating the practice, traditional practice itself, to be sure that the kinds of services that traditional providers give to patients is not harmful, and it's also following scientific guidelines. So that's something that is ongoing. But again, what you have to keep in mind is they still fall under the private sector. Again, private, not for, well, hopefully. Yeah, most of them call themselves not-for-profit in the sense that they provide services and tell you whatever you have to offer, you can offer it. Not necessarily that some don't charge. They say, well, whatever you can offer, you offer it. So we many times classify them as not-for-profit, but depending on how it plays out in your country, you can push them whichever way. Bringing them on board for NHI is an issue that has been discussed. But the problem, again, is that you cannot regulate. NHI will not be able to pay a traditional provider because we can't really access what services you've given, quantify how much it costs, and find the equivalent of that service elsewhere to reimburse you. But what will be encouraged will be to train and regulate the private providers. Perhaps it will be a way to bring them on board, and then such process will be generated in such a way that you will be able to identify how to pay them, reimburse them, which is an issue. But yeah, I don't have a total answer for you, but yeah, I'm thinking about it. Yes, H, finally.
I have two, actually.
Okay.
First, at the beginning, your first slide, there was a slide on the left, a black one. I was wondering if you could provide the context for that. Second, I want to agree with what Chris John said about the resemblance between the status of the illnesses besetting Southern Africans, Black South Africans, and those besetting indigenous people here in the U.S. And I was also thinking of as well the ones in Canada and in Australia as well. It seems to me that the difference, though, is that unlike those places, in South Africa, the beset population radically outnumbered the colonizers. And so maybe in that sense, South Africa is more akin to Brazil or something like that. Although I don't think Brazil went through apartheid. I don't think we could call it that. Though the Brazilian favela outlay looks very much like the shanty towns for some reason. I was wondering to what degree this quantitative analysis part you're talking about has entered the discussion of health. Because when you look at a sign like this, what you see is that Southern Africans have been through what could only really be called a runaway greenhouse racial effect. Like an attempt to dominate them that was so rabid and so out of control that it beset them in every possible way. So I'm wondering to what degree that is part of the health analysis. To what degree do South Africans, do they confront their history with language this blatant about what's happened to them? Or is it, because even hearing you talk, you're obviously very educated and very skilled and a little bureaucratic, and I don't mean this as a put down. I'm just saying that seems to be the way this stuff is talked about, as though that didn't happen, as though something that grotesque and out of control wasn't the way people were treated. So if you could comment on that, please.
Yeah, let me start with that last one. It's something that has been discussed severally. Now, what happened was when apartheid ended, Mandela came on board. There was what they call the Truth and Reconciliation Committee, TRC, headed by Archbishop Desmond Tutu. The outcome of that was that let's keep the past. Okay, yeah, that's a problem. Now, the black population now are feeling like we've been let down. We wanted reparation. We wanted some kind of closure. We wanted whatever, rather than forget about the past and move on and as if it never happened. Let's get something done. So they felt Mandela let them down.
treat it the way we treat terrorism here,
Yeah.
where it's just part of everything.
But unfortunately, since it's something that has permeated all walks of life, people feel if we raise this again, then we are also raising racism. And it's something they don't want to raise again. We don't want to now say, well, it's now our turn as blacks to raise this as racism or something that has happened to us. It will now be seen as racism. So it's a hard one, and you see sometimes I tread on this carefully. But you don't want to raise it up again, and it becomes racism. The Truth and Reconciliation Committee was seen as, well, let's talk about our problems, and let us come to common grounds and bury old bags, never open them again. So that's a problem, which I personally feel, well, there should be ongoing kind of dialogue, ongoing kind of to raise these issues to the fore. But the current generation, someone said that the current generation is even more angered than their fathers because they felt they were let down by their fathers. Their fathers didn't act the way they felt they should act. So they become even more violent than the fathers were or mothers were. And their fathers and mothers acted that way because of the outcome of the Truth and Reconciliation Committee, and Mandela's succumb to pressure not to open that up, because that was one of the fears that the whites had when they relinquished power, that will you do to us what we did to you when we gave you power? And then the agreement was we wouldn't do to you what you did to us when we gave you power. So part of it comes from that kind of, then the other one, I didn't get exactly, you talked about South Africa being akin to Brazil in some sense.
Well, in the sense, South Africa being akin to Brazil in the sense that you have this beset population that outnumbers the colonizers to a great degree.
We do. I don't know Brazil that much, but the much I know about Brazil is the issue of inequality, which of course springs from having something similar to that. Yes, the number of colonizers is actually small, 10% compared to 90% guys that were colonized, which is kind of painful.
Okay, thank you so much. That was a great conclusion to this year, which I will apologize publicly for missing a lot of colloquia this semester. It couldn't be avoided, but this one and the others I've seen have made me realize why I regret it so much. So thank you all for a wonderful semester. I think there might be a couple of questions that people will have for you afterwards, but I think the fellows are all ready to head for lunch, and since Harry wrapped things up, we can take off now. So thank you all.
Thanks.